Welcome to the deep dive. Today, we're embarking on a journey into a really critical area of your health, understanding hyperlipidemia.
That's right, and specifically its central role in atherosclerosis.
We've got some great material here,
Mm.
drawing from comprehensive chapters in Rutherford's vascular surgery and endovascular therapy.
hmm
Think of this as your shortcut, really, to grasping this major health challenge. We want to cut through the complex medical jargon to what really matters for you.
And it's a story with significant impact. Cardiovascular disease, our sources really emphasize this. It remains the leading cause of death in industrialized nations.
Goal number one. Wow.
Yeah, it accounts for over 31% of deaths globally. So understanding the underlying mechanisms is truly vital.
Absolutely. And at the heart of many of these issues is atherosclerosis.
Hmm.
This isn't some new discovery, right? We've understood it for, what, over 6 decades?
At least. And the name itself is quite vivid, isn't it? From Greek words meaning gruel and hard.
Gruel and hard. Paints a picture, definitely. Like our arteries are, well, hardening and thickening.
It's a powerful image, yeah. And our sources clearly point to hyperlipidemia, high levels of fats in the blood as a primary driver in this process.
Okay, so hyperlipidemia is key.
It is, alongside other major risk factors like hypertension, cigarette smoking, and of course a positive family history.
Can't forget genetics.
Never. And it's also worth noting factors like diabetes mellitus, obesity, lack of exercise, and just a poor diet. They all contribute significantly to the overall risk landscape for you.
Okay, so hyperlipidemia is a major piece of the puzzle. But what's actually happening, like down at the molecular level, with this high cholesterol and those inflammatory cells the sources mentioned?
Well, what's fascinating here is the synergy, you could say, elevated cholesterol levels in your blood, particularly what we call LDL cholesterol.
Oh, the bad one.
Often called that, yes. That, combined with the presence of inflammatory cells, creates a kind of vicious cycle within the artery walls. It really drives the development of those atherosclerotic plaques. One fuels the other, you know?
Right. And it sounds like bringing those high cholesterol levels down, well, it has a really significant impact, according to the data.
Oh, it does. A huge impact. Studies have shown that even a 30% to 50% reduction in LDL levels isn't just about changing a number on a lab report.
More than that.
Much more. It translates to a major victory against heart disease, significantly reducing your risk of cardiovascular mortality.
Wow.
In fact, between 1980 and 2000, effectively lowering cholesterol actually decreased deaths from atherosclerotic cardiovascular disease by about 1/3.
One-third. That's remarkable.
It really is a huge public health success story in many ways.
And that really highlights why we have guidelines like the ACHA guidelines for managing lipids we'll touch on. It's all rooted in this compelling evidence.
Precisely. And to truly appreciate how far our understanding has come, it's kind of helpful to look back briefly.
A little history lesson.
Just a bit. The idea that dietary fat and cholesterol play a role in atherosclerosis isn't exactly new. As early as 1910, a German scientist found strikingly high levels of cholesterol right there, inside human aortic plaques.
1910. That's quite a while ago. And then came the studies in animals that helped solidify that link.
Yes, exactly. Just 3 years later, in 1913, a Russian pathologist made a significant leap. He actually induced atherosclerosis in rabbits,
Ow.
simply by feeding them a diet loaded with cholesterol. That was a crucial early piece of the puzzle, demonstrating a direct connection in a living organism.
And it wasn't just happening in the lab, right? Doctors started to connect the dots in their patients as well.
Exactly. In 1919, an American clinician linked changes seen on electrocardiograms, ECGs, to the chest pain of angina.
Which we now know is often caused by.
Often a direct result of atherosclerosis in the heart's arteries, yes. This was followed by the recognition of familial hypercholesterolemia.
That's the genetic one.
Right, a genetic condition causing very high cholesterol levels from birth. And then eventually, the mapping of the intricate pathways the body uses to actually create cholesterol.
So a steady march of discovery.
Yeah.
And our sources point to some really pivotal breakthroughs in the last 50 years or so.
Absolutely pivotal. The identification of the LDL receptor, think of it as the keyhole on our cells that grabs cholesterol from the blood.
Okay.
And the development of statins, those HMG-CoA reductase inhibitors that help lower cholesterol production in the liver. Those two have fundamentally changed how we approach and treat hyperlipidemia.
Game changers.
Totally. And more recently, the discovery of the SREBP1 protein and its role in regulating how much LDL is in our system has added another crucial layer to our understanding.
Okay, so we know cholesterol is central to this whole process. But you mentioned earlier it's like oil and water. Since it's not water-soluble, how does it actually travel around in our watery bloodstream?
Ugh, great question. This is where lipoproteins come into play. Think of lipids like cholesterol and triglycerides as being like oil. They need a special transport system to move through water-based solutions like blood.
Makes sense.
That's the job of lipoproteins. They're like tiny delivery packages. They have a core of these water-repelling
The
lipids.
fats.
Right, the fats. And that core is surrounded by an outer shell that actually loves water. It's made of phospholipids and specific proteins called apolipoproteins.
So the shell makes it soluble.
Exactly. This clever design allows them to dissolve in your blood and get where they need to go.
So these lipoprotein packages have specific jobs then. What are their main functions?
Well, their primary role is to shuttle lipids from your intestines after you've digested food, and also from your liver, where lipids are produced too,
Okay, intestine and liver.
and deliver them to all the cells in your body. These lipids are then used for everything from generating energy and storing it to building cell membranes, synthesizing vital hormones, lots of jobs.
And those apolipoproteins on the surface, they do more than just make it soluble.
Oh, yes. Think of them as the address labels and maybe even the keys on these packages.
Address labels and keys. I like that.
They help the lipoproteins bind to specific receptors on cell surfaces, making sure the lipids get delivered to the right place. And they also act as cofactors, helping enzymes process the lipids inside.
And there's a whole variety of these lipoprotein packages, right? Each with slightly different cargo and destinations.
Exactly. Our sources highlight 5 major types you should be aware of. Chylomicrons, VLDL,
VLDL.
very low density lipoproteins. Then IDL, intermediate density lipoproteins. LDL, low density lipoproteins. And finally, HDL, high density lipoproteins.
Okay, quite a few.
Yeah, each has a slightly different mix of fats and proteins, which affects its size, its density, and ultimately its role in your body.
Let's start with the first one then, chylomicrons. What's their main purpose?
Okay, chylomicrons. They're the workhorses of what we call the exogenous pathway.
Exogenous meaning from outside.
Exactly, dealing with fats that have come from your diet. They're formed inside the cells, lining your small intestine, the enterocytes, after you absorb dietary fats and also any fats recirculated from bile.
Gotcha.
They're the biggest lipoproteins, huge actually, and they contain a specific marker, an apolipoprotein called ApoB48. What's really key is that triglycerides make up about 90% of their fat content.
90% triglycerides.
Yeah, think of them as massive triglyceride delivery trucks heading out right after a meal. That's why sometimes after a really fatty meal, your blood plasma might look a bit milky.
Oh, really?
Yep, that's the chylomicrons in action, that lipemia.
So what happens to all those triglycerides these massive chylomicrons are carrying?
Well, there's an enzyme in your bloodstream called lipoprotein lipase, LPL for short. Think of it as a molecular scissor.
Snip, snip.
Exactly. It gets to work snipping those triglycerides off the chylomicrons into smaller fatty acids. These fatty acids can then be taken up by your peripheral tissues like muscle for energy or fat tissue for storage.
And what's left of the chylomicron?
What's left is a smaller particle called a chylomicron remnant. It's now relatively richer in the dietary cholesterol it was carrying. This remnant then travels to the liver for processing.
Okay.
And interestingly, even though their main job is transport, there's growing evidence suggesting these remnants themselves might actually contribute to atherosclerosis. They might be atherogenic.
Huh. So even the delivery truck leftovers might cause problems.
Yeah.
Okay, so that's the exogenous pathway dealing with dietary fats. What about the endogenous pathway? That involves VLDL.
Right. The endogenous pathway starts in the liver. That's where VLDL is assembled.
Very low density lipoprotein.
Right. These lipoproteins carry cholesterol and triglycerides that originate from the liver itself, either newly made or coming from other fat stores. Each VLDL particle has specific apolipoproteins, ApoC, ApoE, and importantly, one molecule of ApoB100.
ApoB100, that sounds important.
It is. Another key address label. Similar to chylomicrons, their main fat component is triglyceride, making up around 70% of their lipid content.
And just like with chylomicrons, does that LPL enzyme, the scissors, play a role with VLDL?
Absolutely. The same enzyme, LPL, also acts on VLDL circulating in the bloodstream. It releases those fatty acids for your body to use.
Okay.
And as the triglycerides get removed, the VLDL particles shrink and become denser. They transform first into what we call VLDL remnants, and then into intermediate density lipoproteins, or IDL.
So VLDL becomes IDL.
Essentially, yes.
Yeah.
This whole process lets your body transport and use stored triglycerides for energy, especially between meals or when you're fasting.
Now, IDL is highlighted in our sources as increasing the risk of cardiovascular disease. Why is that?
Well, what's important to understand about IDL particles is that they carry a significant amount of both cholesterol esters and triglycerides.
Okay.
And studies have indicated a direct link between elevated IDL levels and an increased thickness of the carotid artery lining the CIMT. That's a key early sign of atherosclerosis.
Oh.
These IDL particles also tend to be more prevalent in people with metabolic syndrome and type 2 diabetes, which likely contributes to their increased cardiovascular risk.
Which brings us then to LDL, often labeled the bad cholesterol. How does that fit into this whole picture? Where does it come from?
So LDL is actually formed from IDL. Through the ongoing action of LPL and another enzyme called hepatic lipase, even more triglycerides are removed.
So it gets even smaller and denser.
Exactly.
Yeah.
And LDL is generally considered the most atherogenic, the most likely to cause atherosclerosis of all the lipoproteins. Each LDL particle contains just one crucial apolipoprotein, that ApoB100 we mentioned.
The address label.
Right. And it acts like a specific key, allowing LDL to bind to LDL receptors on the surface of your cells. That binding is how cells take up the cholesterol they need.
And the number of those LDL receptors on our cells is really important, isn't it?
Absolutely critical. The number of LDL receptors on a cell surface is directly regulated by how much cholesterol is already inside the cell. It's a feedback loop.
Okay, how does that work?
Well, when intracellular cholesterol levels are low, the cell makes more LDL receptors. That means more LDL gets pulled out of the bloodstream, and your plasma LDL levels go down.
Makes sense. Low supply, increased demand.
Exactly. Conversely, when cholesterol levels inside the cell are high, the cell puts the brakes on making receptors. Fewer receptors means less LDL gets cleared from the blood, and your plasma LDL levels go up.
And high LDL in the plasma.
It is bad news! As our sources emphasize, high levels of LDL in your plasma can directly contribute to the development and progression of atherosclerosis. There's a strong link.
It's incredible that the discovery of this LDL receptor actually earned a Nobel Prize.
It was absolutely groundbreaking work by Brown and Goldstein, actually, back in 1985. They fundamentally revealed how the body manages its cholesterol uptake.
And the liver plays a big role.
Huge. They found the liver is the primary site, accounting for over 70% of all LDL receptors in the body. And here's something fascinating. Humans are actually born with a high number of these receptors and naturally low LDL levels.
Really? How low?
Typically around 25 to 30 mg/dL. Very low compared to typical adult levels in Western societies.
So what happens?
Well, the modern Western lifestyle, often high in calories, saturated fat, low in physical activity, can unfortunately lead to a downregulation of these vital LDL receptors. Fewer receptors, higher LDL-C.
So lifestyle choices have a direct biological impact on our body's ability to clear LDL. Okay. Now let's talk about HDL, this so-called good cholesterol. What's its role in all of this intricate lipid transport system?
Right, HDL. It's synthesized by both the liver and the intestine. It starts out as a relatively empty, kind of disc-shaped particle that's rich in a different key apolipoprotein called ApoAI.
Okay, ApoAI for HDL.
Correct. Its primary mission is essentially to scavenge excess cholesterol from cells throughout your body, including, importantly, from those cells in the artery walls.
How does it pick it up?
There's a key transporter protein called ABC transporter A1 that facilitates this pickup. Once HDL grabs the cholesterol, an enzyme called LXACAT converts it into cholesterol ester. This form is more hydrophobic, so it moves into the core of the HDL particle.
And that changes its shape.
It does. It causes the HDL to mature into a more spherical shape. HDL can then acquire even more cholesterol through other transporters like ABCG1 and SRB1.
So it loads up on cholesterol, and then it acts like a garbage truck, taking that cholesterol back to the liver for disposal.
That's a great analogy. Exactly. HDL can directly deliver its cholesterol cargo back to the liver via a specific receptor called SRB1.
Okay.
Alternatively, it can do a swap. It can exchange its cholesterol for triglycerides from VLDL particles. This happens through the action of the cholesterol ester transfer protein, or CETP.
A swap. So where does the cholesterol end up then?
Well, the cholesterol that was on HDL gets transferred to VLDL, which, as we discussed, eventually becomes LDL. That LDL can then be taken up by the liver via the LDL receptor.
Okay, so it still gets back to the liver, just indirectly.
Right. This whole process, picking up cholesterol from the periphery and getting it back to the liver, is known as reverse cholesterol transport.
Reverse cholesterol transport.
And it's a major reason why HDL is considered anti-atherogenic. It actively helps remove cholesterol from the arteries, counteracting the buildup that leads to plaque formation. Hence, the good cholesterol label.
Okay, we've covered the transport system, the lipoproteins, LDL, HDL, the whole crew. Now, let's really delve into the core issue, how atherosclerosis actually develops, the pathophysiology our sources describe.
Right. So atherosclerosis, as our material explains, fundamentally begins with damage or dysfunction of the arterial endothelium.
That smooth inner lining of the arteries.
Exactly. When it's healthy, it's a very smooth, very resistant to things sticking to it. But factors like, say, an unhealthy atherogenic diet can cause damage or activate it. This prompts the endothelial cells to start expressing adhesion molecules on their surface, like VCM1.
Adhesion molecules,
Right.
like Velcro.
Pretty much. They act like Velcro, attracting and binding to circulating white blood cells, specifically monocytes and T lymphocytes.
So these immune cells start sticking to the injured lining. What happens next in this process?
Well, in the presence of elevated LDL, the bad cholesterol, and maybe low HDL, the good cholesterol, these monocytes that have stuck to the wall actually migrate beneath the endothelium into the artery wall itself, the intima.
They go inside the wall.
They do. Once there, they transform into macrophages, which are like scavenger cells, and they start engulfing cholesterol, particularly LDL that has also entered the wall and become modified or oxidized.
Engulfing cholesterol.
Yeah. As they accumulate more and more cholesterol, they transform into those characteristic foam cells we mentioned earlier. They get that foamy appearance from all the droplets of cholesterol ester building up inside them.
Foam cells, okay.
These foam cells are bad news. They're more likely to stick around, they release inflammatory signals, and they also stimulate the smooth muscle cells that are normally deeper in the artery wall to multiply and migrate up into the inner lining, the intima.
So the wall starts thickening.
Exactly. This leads to a thickening of the intima and the eventual formation of a plaque, which typically develops a fibrous cap over this growing core of lipids and cellular debris. And it's crucial to remember this isn't just happening in one spot. It can occur throughout your entire vascular system.
And you mentioned the damaged endothelium becomes more permeable, allowing those bad lipoproteins to get into the artery wall more easily.
Precisely. A damaged or dysfunctional endothelium acts like a leaky barrier. So LDL, along with other potentially harmful lipoproteins like VLDL remnants, IDL, and even those Chylomicron remnants we talked about, can more readily pass through into the artery wall.
And once inside the wall.
Once inside the artery wall, LDL is particularly susceptible to oxidation by free radicals present in that inflammatory environment. This oxidized LDL is especially problematic.
Why is oxidized LDL worse?
Because it's even more pro-inflammatory. It really fuels the fire. And tissue macrophages have special scavenger receptors that readily gobble up this oxidized LDL. This leads to the formation of even more lipid-filled foam cells. This accumulation of foam cells is what forms the fatty streak considered the earliest visible sign of an atherosclerotic lesion.
So it's a self-perpetuating cycle then. Damage leads to inflammation, which lets LDL in, which gets oxidized, creating more inflammation in foam cells.
Exactly. It feeds itself. As this continues, the foam cells eventually die off, releasing their accumulated lipids and cellular junk, contributing to the formation of the lipid-rich core of the growing atherosclerotic plaque.
Does the artery just keep getting narrower?
Well, interestingly, the artery wall initially tries to compensate. It expands outwards, a process called positive remodeling, to try and maintain the size of the lumen, the channel for blood flow, even as the plaque grows within the wall.
So it bulges outwards first.
Yes. But eventually, as the plaque continues to grow and thicken, this compensation isn't enough. The plaque starts to encroach into the lumen, narrowing the opening and restricting blood flow to the tissues downstream.
And this is where the critical distinction between stable and unstable plaques comes into play, right? Our sources mention this.
Absolutely critical distinction. Stable plaques generally have a thick, protective, fibrous cap overlying a relatively solid, less inflamed lipid core. These are less likely to cause sudden, acute problems.
Okay, stable is better.
Definitely. Unstable or vulnerable plaques, on the other hand, are the really dangerous ones. They're characterized by a thin, fibrous cap, a large, often liquidy and highly inflamed lipid core, and lots of inflammatory cells.
Thin cap, big inflamed core. Sounds risky.
Extremely risky. They are much more prone to ulceration or outright rupture. When that thin cap breaks, the highly thrombogenic material inside the plaque gets exposed to the blood.
Thrombogenic meaning? It causes clots.
Exactly. It triggers rapid formation of a blood clot right on the plaque surface. This clot can suddenly and completely block the artery. That's the underlying cause of acute events like heart attacks and most strokes.
Wow. So it's the unstable plaque rupture that often causes the sudden vent.
Very often, yes. And our sources are clear. There's direct dose-dependent relationship between your LDL levels and the likelihood of both forming plaques in the first place and developing atherosclerotic cardiovascular disease, or ASCVD,
Dose dependent.
meaning the higher your LDL-C, the higher your risk. Conversely, very low LDL levels, like those seen at birth maybe, are associated with a very low probability of plaque formation. As LDL-C increases, the risk progressively climbs.
Okay, that really underscores the importance of managing LDL. So how do doctors actually go about diagnosing these atherogenic lipid disorders? What are the key things they look for?
Well, the standard approach, recommended for decades now, starting with guidelines like ATP3, is screening. All adults over 20 should ideally get screened every 5 years with a fasting lipoprotein profile.
Fasting, meaning no food.
Usually a 12-hour fast. This profile measures your total cholesterol, your triglycerides, your HDL cholesterol, and your LDL cholesterol.
And if the first check, maybe just total cholesterol, is high.
Right. If an initial non-fasting check shows total cholesterol above, say, 200 milli-GDL, or if HDL is low, maybe below 40 milli-GDL, then a full fasting lipoprotein profile is definitely indicated to get the complete picture and assess your risk properly.
And once they have those numbers, total cholesterol, triglycerides, HDL, LDL, how do they interpret them to understand a person's risk?
Well, total cholesterol by itself isn't the best predictor, actually.
Why not?
Because it's a mix, right? It includes both the good HDL and the bad LDL, and it can be influenced by high triglycerides, too, so it doesn't give you the full story.
Okay, so what is the best predictor?
LDL cholesterol, the LDL-C level, has consistently emerged as the most predictive lipoprotein fraction for atherosclerosis risk. In general, the higher your LDL-C level, the greater your risk. It's pretty much a direct relationship.
And HDL?
HDL cholesterol, HDL-C, shows an inverse relationship with risk. Higher levels are generally considered protective, lowering your risk.
So high LDL is bad, high HDL is good.
That's the general principle, yes. And importantly, these risks are additive. So if you have both high LDL-C and low HDL-C, your risk is significantly increased compared to someone with just one of those issues.
What about triglycerides? They're always part of the standard lipid panel. What role do they play in assessing risk? It seems a bit less clear-cut sometimes.
It is a bit more nuanced, you're right. While the really large triglyceride-rich particles, like the initial chylomicrons and large VLDL, aren't considered as directly atherogenic as artery clogging as LDL is.
Okay.
Their smaller remnant forms and IDL, which are also rich in triglycerides, are considered atherogenic. Clinically, elevated triglyceride levels are often a marker for other underlying issues that increase risk.
Like,
Well, high triglycerides are very common in type 2 diabetes and metabolic syndrome. They're also a feature of a genetic condition called familial combined dyslipidemia. In these contexts, high triglycerides definitely signal increased ASCVD risk.
so it's a red flag, even if not the direct cause itself sometimes.
Exactly. It tells you there's likely an underlying metabolic disturbance that needs attention. And it's also important to note, very, very high triglyceride levels, say, over 1,000 milli-GDL, carry a separate distinct risk of causing pancreatitis, inflammation of the pancreas.
Right, pancreatitis.
Yeah.
Different issue, but still serious.
You okay?
Our sources also mention something called atherogenic dyslipidemia. What exactly does that term describe?
Atherogenic dyslipidemia is a specific pattern of lipid abnormalities that's very commonly seen in individuals with type 2 diabetes and metabolic syndrome. It's sort of a trifecta.
A trifecta. Okay, what are the three parts?
Typically, it involves elevated triglyceride levels, low HDL cholesterol levels,
High triglycerides, low HDL.
and often LDL cholesterol levels that might not actually be strikingly high. Sometimes LDL-C can even be in the normal range or even low.
Wait, low LDL-C, but still high risk. How does that work?
Because in this situation, the LDL particles themselves tend to be different. They're often smaller and denser, small, dense LDL.
Small, dense LDL. Why is that worse?
These smaller, denser particles are thought to be more easily able to penetrate the artery wall, they stick around longer, and they're more easily oxidized. So they're considered more atherogenic, particle for particle, than larger, fluffier LDL.
Ah, okay, so the quality matters, not just the quantity measured by LDL-C.
Precisely. And studies have shown that in this context of atherogenic dyslipidemia, measuring the number of LDL particles present, LDLP, rather than just the cholesterol concentration within them, LDL-C, might be a better indicator of risk.
How do you measure particle number?
There are specialized tests, like NMR spectroscopy, that can measure LDLP. Also, since each atherogenic lipoprotein particle, LDL, IDL, VLDL remnants LPA, contains one molecule of ApoB100.
The address label again.
Right. Measuring the total level of ApoB100 in the blood can also give you a measure of the total number of these potentially harmful particles and might be a better risk indicator than LDL-C alone in these patients.
That makes sense. It's not just about the total cholesterol cargo, but how many potentially harmful delivery trucks are on the road. And our sources also highlight the importance of non-HDL cholesterol in risk assessment. What's that?
Yes, non-HDL-C. It's actually emerged as a very useful and often stronger predictor of atherosclerotic risk than LDL-C alone in many studies. And it's super simple to calculate.
Oh.
You just subtract your HDL-C level from your total cholesterol level. Total cholesterol minus HDL-C equals non-HDL-C.
Okay, simple enough. What does it represent?
It essentially represents the total amount of cholesterol carried in all the potentially atherogenic ApoB-containing lipoproteins. That includes LDL, IDL, VLDL remnants, and another one called LPA, everything except the good HDL.
So it captures more of the bad stuff.
Exactly. The ATP3 guidelines actually designated non-HDL-C as a secondary target of therapy right after the primary LDL-C goal, especially in individuals who also have high triglyceride levels, like above 200 milli-GDL.
Because LDL-C might be misleading then.
It can underestimate the risk when triglycerides are high because a lot of the cholesterol might be in those VLDL remnants and IDL, not just LDL. Non-HDL-C captures all of that. For most people, a standard lipid profile giving you LDL-C, HDL-C, triglycerides, and allowing you to calculate non-HDL-C is sufficient for initial risk assessment.
Okay. And you mentioned lipoprotein A, or LPA. That's another component that can influence risk, right?
Yes, LPA. It's a distinct lipoprotein particle, kind of like an LDL particle with an extra protein called ApoA attached. It has been associated with an increased risk of atherosclerosis and cardiovascular events, particularly ischemic stroke, in many studies.
So should everyone get it checked?
Well, that's debated. Our understanding of its metabolism is still kind of incomplete. And critically, we don't yet have strong evidence from large intervention trials showing that specifically lowering LPA directly reduces cardiovascular risk. Plus, effective therapies specifically targeting LPA are still limited, though some are in development. So, who should get it checked? The European Atherosclerosis Society suggests considering LPA testing in certain individuals, those at moderate or high overall risk, maybe those with a strong family history of early heart disease, or people who keep having events despite good control of other risk factors like LDL on statins. It's more selective testing for now.
It's really striking to see how our understanding and the guidelines for managing these lipid disorders have evolved so much over the years. Our sources give a nice overview of this progression.
It truly is a fascinating journey watching the science translate into clinical practice. The first major set of U.S. guidelines, ATPA back in 1988, was really focused on raising awareness. Education and lifestyle intervention were the mainstays.
Drugs weren't used much then.
Drug therapy was generally reserved for people with really high LDL levels, like over 190 milli-GDL, or those over 160 milli-GDL if they also had multiple other heart disease risk factors.
Then came ATP2 in '93. What changed?
ATP2 built on that foundation, but it specifically added recommendations for secondary prevention. That means treating people who already had established coronary artery disease.
And the goal was lower for them.
Yes,
Right.
it set a more aggressive target LDL-C goal of below 100 milli-GDL for this high-risk group. It also noted something important, that heart attacks often happen even when arteries aren't narrowed by, say, 70% or more. This introduced the concept of the vulnerable plaque we talked about.
The unstable one.
Right. And it suggested that statins, which were becoming more widely used, might have stabilizing effects on these plaques beyond just lowering cholesterol.
And then ATP3 in 2002 sounds like it was a major leap forward, really based on evidence.
Absolutely. ATP3 was heavily influenced by the results of large clinical trials, especially with statins. It ushered in a much more proactive and, frankly, aggressive approach to risk assessment. It formally incorporated the Framingham Risk Score to estimate an individual's 10-year risk of developing coronary heart disease.
The 10-year risk score. People might have heard of that.
Very likely. It also introduced the important concept of CHD risk equivalence.
Yeah.
Conditions like diabetes or having other forms of atherosclerotic disease like peripheral artery disease or carotid artery disease were recognized as carrying a similarly high risk to already having known coronary heart disease. They were treated just as aggressively.
So it broadened the definition of high risk.
Exactly. And furthermore, ATP3 categorized patients into different risk strata: high, intermediate, and low, and set specific target LDL and non-HDL-C goals for each category. It became much more stratified.
And the guidelines have continued to evolve since then, right? With the 2013 and 2018 ACHA updates.
Yes, indeed. The 2013 ACCA guidelines shifted the focus a bit. Instead of just targeting specific LDL numbers for everyone, they identified 4 specific groups of patients who were proven in trials to benefit most from statin therapy and recommended specific intensities of statin therapy, high, moderate, or low for those groups.
So focusing on who benefits most from which statin dose.
Right. Then the 2018 ACAC guidelines refined this further. They incorporated findings from newer trials, especially those involving non-statin drugs like PCSK9 inhibitors and ezetimibe. They brought back some emphasis on achieving certain LDL threshold reductions, especially for very high-risk patients.
Like getting below 70.
Exactly. For patients with very high-risk ASCVD, they recommended aiming for an LDL-C below 70 mg/dL, often requiring adding ezetimibe or even a PCSK9 inhibitor if statins alone weren't enough. They also strongly recommended high-intensity statins for anyone with an LDL-C starting above 190 mg/dL, suggesting familial hypercholesterolemia. So it's become increasingly sophisticated and personalized.
It's interesting how the specific management of dyslipidemia in people with peripheral artery disease, PAD, has kind of fit into this evolution.
Yeah, initially, most of the big statin trials were focused on coronary heart disease outcomes, heart attacks, cardiac death. Any benefits seen in patients with PAD were often secondary findings or subgroup analyses.
And PAD patients sometimes got less aggressive treatment.
Unfortunately, yes. Data has shown that individuals with PAD often tend to receive less intensive risk factor modification, including lipid lowering, compared to those with known coronary artery disease, even though their risk is often just as high, if not higher.
But did any big studies really show benefits for PAD?
Oh, yes. The Landmark Heart Protection Study, HPS, was pivotal. It included thousands of patients with PAD and other vascular diseases. It provided strong evidence that statin therapy significantly reduced the risk of major peripheral vascular events, like needing revascularization or amputation in both patients with known PAD and other high-risk individuals.
So HPS really supported statins for PAD patients specifically.
Absolutely. It strongly supported using statin therapy as a cornerstone of treatment for virtually all patients with PA, regardless of their initial cholesterol level, actually.
And even some of the earlier non-statin trials provided hints about the benefits of lipid therapy for atherosclerosis beyond just the heart.
That's right. Studies like POSCH, which used a type of intestinal bypass surgery to lower lipids, and CLAS, which used a combination of older drugs, cholesterol, and niacin. These offered early angiographic evidence.
Angiographic, looking at artery images.
Yes, showing that aggressive lipid therapy could actually slow down, halt, or even slightly reverse the progression of atherosclerosis seen on angiograms. And the long-term follow-up of the POSCH study even suggested that the surgery group had a lower risk of developing an abnormal ankle brachial index, which is a key diagnostic measure for PA.
So the principle held lowering lipids helps atherosclerosis wherever it is. Okay, so we clearly understand the why managing dyslipidemia is crucial. What about the how? Let's talk non-pharmacologic approaches first. Lifestyle changes, how big a role do they play?
They play an absolutely fundamental role. They were strongly emphasized back in ATP third with the whole concept of therapeutic lifestyle changes, or TLC. These should be recommended for everyone at risk.
TLC. And the specifics depend on the person's risk.
Yes, the intensity and specific goals of TLC are often tailored to an individual's target LDL goal and their overall cardiovascular risk category. But the core components are diet and exercise.
Okay, let's break down TLC. What about diet? What are the key recommendations?
Dietary changes are definitely a cornerstone. A predominantly plant-based dietary pattern tends to be ideal. Think lots of fruits, vegetables, legumes, whole grains. These diets are naturally lower in saturated fat and total fat.
And specific targets.
The guidelines often recommend reducing saturated fat intake to less than 7% of total daily calories and limiting dietary cholesterol to under 200 milligrams per day.
Less saturated fat, less cholesterol.
Right. Also, incorporating things like plant sterols and stanols found in fortified margarines or available as supplements about 2 grams a day can help lower LDL. And increasing intake of viscous soluble fiber like from oats, beans, psyllium, aiming for 10-25 grams a day, also helps.
Plant sterols and soluble fiber. Okay. Anything to avoid.
Absolutely crucial. Avoid trans fats, partially hydrogenated oils. They're really detrimental to lipid profiles and overall cardiovascular health.
Trans fats are out. What about healthy fats?
Good point. Diets like the Mediterranean diet, which is rich in monounsaturated fats from olive oil and includes nuts and fish, have shown significant cardiovascular benefits in large studies like the pre-dimed trial.
So Mediterranean diet gets a thumbs up.
Definitely. And for individuals struggling with obesity, significant weight loss, sometimes achieved through bariatric surgery, can also lead to substantial improvements in lipid profile.
Okay, diet is key.
Yeah.
And of course, physical activity is the other pillar of TLC.
Absolutely critical. Regular, moderate intensity physical activity is strongly recommended. The goal is often framed as expending about 200 kilocalories per day through activity.
What's that achieve for lipids?
Regular activity like brisk walking, jogging, cycling, swimming, it can help lower LDL and triglyceride levels. It can raise the good HDL cholesterol, and it also improves insulin sensitivity, which is beneficial for overall metabolic health.
And how much activity are we talking about?
The general recommendation, like from the ACIA, is to aim for 30 to 60 minutes of moderate intensity aerobic activity on most, if not all, days of the week. So ideally 5 to 7 days per week.
Consistency is key.
Very much so.
Now, when lifestyle changes alone aren't enough to reach the target lipid levels, or for individuals who start out at very high risk, that's where pharmacologic therapy comes in. And statins are generally the first-line medication, right? As our sources clearly indicate.
Yes, statins. They are HMG-CoA reductase inhibitors. They are, without doubt, the most effective class of medications we currently have for lowering LDL cholesterol.
How much do they lower it?
It varies by the specific statin and the dose, but typically they reduce LDL-C levels by a significant margin, anywhere from about 18% on the low end to as much as 60% or even slightly more with the high-potency ones at high doses.
That's a big range.
It is. They also offer modest benefits in increasing HDL-C levels, maybe 5-20%, and reducing triglycerides, perhaps 7-30%, but their main power is LDL lowering.
And the clinical trial evidence is strong.
Overwhelmingly strong. Decades of large-scale clinical trials have unequivocally demonstrated that statins significantly reduce the risk of major cardiovascular events, heart attacks, strokes, need for bypass or stenting, peripheral artery events, and they improve overall survival rates, all with a generally low risk of serious side effects.
What about side effects? People hear about muscle aches.
That's the most commonly discussed one. Minor muscle aches or myalgias can occur. Significant muscle damage called rhabdomyolysis is actually very rare. Transient elevations in liver enzymes can also happen, but usually aren't serious. Higher doses might slightly increase the risk of developing new onset diabetes in some individuals, but for most people at risk, the cardiovascular benefits far outweigh these potential risks.
So the benefit usually outweighs the risk.
For the vast majority of patients who need them, yes. And interestingly, some studies even suggest statins might improve pain-free walking distance in patients with intermittent claudication from PAD.
Oh, really? That's an added benefit.
Potentially, yes. The evidence from trials like 4S, HPS, Prosper, TNT, Jupiter, it's just consistently shown profound benefits across diverse patient groups, including the elderly and those with PAD.
Okay, statins are the cornerstone. But there's a range of other pharmacologic agents available too, right? Used in different situations or sometimes added to statins.
Correct. There are several other classes. Niacin, or nicotinic acid, was actually one of the very first drugs shown to effectively lower cholesterol.
What does niacin do?
It has favorable effects across the board, actually. It can lower LDL-C, lower triglycerides significantly, and it's particularly good at raising HDL-C levels, sometimes by 15-35%.
So why isn't it used first line more often?
Well, it has some challenging side effects, most notably flushing that intense, warm, red, itchy feeling. While aspirin beforehand or extended-release formulations can help, it can still be bothersome. It can also affect liver function, glucose control, and uric acid levels. And some big recent trials combining niacin with statins didn't show the additional clinical benefit expected, despite the improved lipid numbers. So its role has become more niche.
Okay, niacin. What else? Fibrates.
Fibrates, yes. Drugs like gemfibrozil and fenofibrate, these are primarily used for lowering high triglyceride levels. They work as PPAR alpha agonists.
How much do they lower triglycerides?
Quite effectively, often by 25-50%. They also tend to raise HDL-C modestly, maybe 5-15%. Fenofibrate can sometimes lower LDL-C a bit too.
Do they reduce heart attacks like statins?
The evidence is less robust than for statins. Some trials showed they might slow atherosclerosis progression, but major trials haven't consistently shown a significant impact on overall mortality, especially when added to statins. They're mainly for managing severe hypertriglyceridemia to prevent pancreatitis, or sometimes in specific patients with high triglycerides and low HDL, particularly diabetics.
Got it. Then there are bile acid sequestrants. Sounds old school.
They are an older class: cholestyramine, cholestyramine, and a newer one, cholesyvelum. They work in the gut, binding bile acids and preventing their reabsorption. This makes the liver use more cholesterol to make new bile acids, which lowers LDL-C in the blood.
Do they work well?
They lower LDL-C, yes, maybe 15–30%. They're often used with statins to get additional LDL lowering. A big advantage is they aren't absorbed systemically, so low risk of systemic toxicity. Mainly gastrointestinal side effects, constipation, bloating, dyspepsia. Cholecyvelum seems a bit better tolerated. They can also sometimes increase triglyceride levels, so not good if those are already high. And they can interfere with the absorption of other drugs, so timing of doses is important.
Okay. What about ezetimibe? That seems more common now.
Yes, ezetimibe Zetio works differently. It specifically inhibits the absorption of cholesterol right at the brush border of the small intestine.
How much does it lower LDL?
As monotherapy, maybe 15–20%, but it's most often used in combination with a statin. Adding ezetimibe to a statin typically provides an additional 20–25% reduction in LDL-C on top of what the statin is doing.
So good for getting those really low LDL targets.
Exactly. The IMPROVE trial showed that adding ezetimibe to simvastatin in high-risk patients after a heart attack further reduced cardiovascular events compared to simvastatin alone, providing evidence for its clinical benefit when added to a statin.
Okay. Omega-3 fatty acids. Fish oil.
Omega-3s, yes, the EPA and DHA found in fish oil. Observational studies suggest diets high in fish are associated with lower heart disease risk. Some trials, like an early Italian one, suggested that 1 gram daily might reduce the risk of sudden death after a heart attack.
And for lowering lipids.
At higher doses, typically 3 grams or more per day, omega-3s have a definite triglyceride-lowering effect. Prescription high-dose ETA products have shown cardiovascular benefit in certain high-risk patients with elevated triglycerides despite statin therapy, like in the REDUCE-IT trial. But more standard-dose fish oil supplements haven't consistently shown benefit in recent large trials for primary or secondary prevention.
So high-dose prescription for triglycerides, maybe. What about CETP inhibitors? They sounded exciting for a while.
They did. CETP inhibitors block that transfer protein we talked about, the one that swaps cholesterol from HDL for triglycerides from VLDL. The idea was blocking it would raise HDL and maybe lower LDL, which would be good.
And did it work?
Well, they definitely raise HDL levels, sometimes dramatically. But the clinical trial results have been mostly disappointing. The first one, torcetrapib, actually increased mortality due to off-target effects. Others, like dalcetrapib and evacetrapib, failed to show clinical benefit despite raising HDL. Anacetrapib showed a modest benefit but wasn't pursued commercially, so that mechanism hasn't panned out as hoped.
Interesting. Which brings us to the PCSK9 inhibitors. You mentioned them earlier as a real breakthrough.
They truly have been a game changer for specific patient groups. Elarokumab, evolocumab, these are monoclonal antibodies. They work by targeting PCSK9, which is a protein that normally degrades LDL receptors in the liver.
So blocking PCSK9 means more LDL receptors?
Exactly. More LDL receptors stick around on the liver cell surface, which means more LDL gets pulled out of the bloodstream. The result is a really profound reduction in LDL-C levels.
Profound.
Often an additional 50–60% reduction on top of what statins are already doing. We're talking getting LDL levels down to 25–50 milli-DL or even lower in many patients.
And does that translate to fewer heart attacks and strokes?
Yes. Large clinical outcome trials like Fourier with evolocumab and Odyssey outcomes with elarokumab demonstrated that this profound LDL lowering translates into a significant reduction in major cardiovascular events in high-risk patients already on statins.
So who gets these? They're injectable and expensive, right?
They are injectable usually every 2 or 4 weeks, and yes, they are significantly more expensive than statins or ezetimibe. So they're typically reserved for patients who are considered at very high risk and who either can't tolerate statins or, more commonly, who cannot reach their target LDL-C goals, despite being on the maximally tolerated dose of a potent statin, often already combined with ezetimibe.
So for very high risk, needing more LDL lowering.
Right. They are specifically approved for patients with established clinical atherosclerotic cardiovascular disease or those with heterozygous familial hypercholesterolemia who require additional LDL lowering.
And it sounds like there are even more novel therapeutic agents in the pipeline beyond PCSK9 antibodies. Our sources mentioned a few.
Yes, it's a really active area of research, which is exciting. Inclisiran is one generating buzz.
What is it?
It's different from the antibodies. It's an interfering RNA molecule, siRNA. It works inside the liver cells to basically silence the gene that makes PCSK9 protein.
So it stops PCSK9 production.
Exactly. The big potential advantage is much less frequent dosing, maybe just 2 injections per year after the initial doses. It's shown similar LDL lowering to the antibodies and is in late-stage outcome trials now.
Twice a year. That's convenient. What else is new?
Bempedoic acid is another one. It inhibits an enzyme called ATP citrate lyase, which is involved in cholesterol synthesis pathway, but it acts before the step that statins block.
Why is that potentially useful?
It needs to be activated in the liver, not in muscle, so the hope is it might cause less muscle-related side effects than statins, making it an option for statin-intolerant patients. It provides modest LDL lowering and is approved, often used with ezetimibe.
Interesting. Anything targeting LPA specifically?
Yes, that's another exciting area. There are antisense oligonucleotides like pelacarsen, formerly AKCE-APO, LRX, designed specifically to target the production of LPA in the liver. Early trials have shown very significant reductions in LPA levels, like 80–90%. A large outcome trial is underway now to see if lowering LPA actually prevents cardiovascular events. That could be huge if it works.
That'd be a game changer for people with high LPA.
Absolutely. And there are other targets being explored too, like antibodies or antisense drugs targeting angiopoietin-like 3, ANGPTL3, which plays a role in both triglyceride and cholesterol metabolism. Lots happening.
It really seems that combination drug therapy is often the way to go to effectively reach lipid targets in many patients, especially high-risk ones.
Absolutely. It's very common. Combining a statin with a medication that works through a different mechanism is a standard approach. Statin plus ezetimibe is probably the most common combo for further LDL lowering.
Statin plus ezetimibe.
Or sometimes a statin plus a bile acid sequestrant, particularly colesevelam. This can be done whether someone is on a maximal statin dose and still not at goal, or maybe on a submaximal dose due to side effects and needs an extra boost.
And what about for people with high triglycerides too, that combined hyperlipidemia?
For combined hyperlipidemia, high LDL, and high triglycerides, statins are still the foundation because they lower LDL and cardiovascular risk. Then you might consider adding fenofibrate or prescription omega-3s or perhaps niacin in select cases to address the triglycerides and low HDL depending on the specific levels and overall risk.
But you have to be careful with some combos.
Yes, particularly statins and gemfibrozil. That combination significantly increases the risk of muscle toxicity, myopathy, and rhabdomyolysis, and is generally avoided. Fenofibrate is considered a safer fibrate choice to combine with a statin if needed.
Good to know. Did any trials look at achieving really aggressive goals with combos?
The SANS trial was interesting. It targeted very aggressive goals like LDL less than 70 and non-HDL less than 100 in patients with diabetes, using whatever combination therapy was needed. It actually showed some regression of carotid intima media thickness, that early marker of atherosclerosis. But we still need more large-scale trials with hard clinical endpoints, heart attacks, strokes, to fully confirm the benefit of pushing to such ultra-low targets with combination therapy in broader populations.
Finally, our sources touch upon homozygous familial hypercholesterolemia, HFH. That sounds particularly severe.
It is. Homozygous FH is a rare but very serious genetic disorder where individuals inherit two faulty copies of a gene involved in LDL receptor function, usually the LDL receptor gene itself. This results in extremely high LDL cholesterol levels, often over 500 or 600 milli-GDL, right from birth.
And that leads to very early heart disease.
Devastatingly early? Yes. Without aggressive treatment, many individuals with HFH develop severe atherosclerosis and can have heart attacks even in childhood or their teenage years. The groundbreaking work of Goldstein and Brown, which won them the Nobel Prize, was largely based on studying cells from patients with HFH, which helped them figure out the whole LDL receptor pathway.
How do you even treat LDL levels that high? Standard drugs probably aren't enough.
Often they aren't. Statins help, but they rely on having some functional LDL receptors. Management is complex and usually involves a combination of approaches. LDL apheresis is a key therapy.
Apheresis, like dialysis.
Similar idea. It's a physical process where the patient's blood is removed, passed through a machine that specifically filters out the LDL particles, and then the blood is returned to the body. It has to be done regularly, often every week or two.
Wow. Are there specific drugs for HFH too?
Yes, several specialized medications have been developed. Lomidopide inhibits the assembly of VLDL in the liver. Mipomersen is an antisense drug that reduces the production of ApoB100. And the PCSK9 inhibitors have also proven very effective in many HFH patients, depending on their specific genetic mutation. So treatment is highly specialized, but has improved significantly.
It's clear managing lipids is complex. Our source material even includes treatment algorithms, sort of like flowcharts that guide clinicians.
Exactly. These algorithms typically integrate an individual's overall ASCVD risk score, their baseline LDL-C level, whether they have diabetes, their age, and other factors.
And they guide decisions on.
They provide a structured framework. when to strongly recommend lifestyle changes, when to initiate statin therapy, what intensity of statin to use, high versus moderate,
Right.
what the target LDL-C or percent reduction should be, and importantly, when to consider adding non-statin agents like ezetimibe or PCSK9 inhibitors if the goals aren't met. It really illustrates the comprehensive and increasingly personalized approach that's now used to manage this complex condition.
It emphasizes that tailored approach based on individual risk.
Exactly. Starting with lifestyle for everyone, then escalating therapy systematically to help patients achieve their individualized target lipid levels and ultimately reduce their risk of heart attacks and strokes.
Okay, let's try and bring all of this together. We've covered a lot of ground. It seems abundantly clear that hyperlipidemia plays a really critical role in the development of atherosclerosis and ultimately cardiovascular disease.
That's absolutely the core message, isn't it? It's a major modifiable risk factor. But the good news is, as we've explored, our understanding of the underlying mechanisms, how to effectively diagnose it, and the multitude of ways we can now manage it has just advanced dramatically over the decades.
It's truly been an impressive journey of scientific discovery, from those early observations of cholesterol actually inside artery walls over a century ago,
Right, back in 1910.
to our current, really sophisticated understanding of lipoprotein metabolism, the receptors, the enzymes, the whole intricate dance, and the development of powerful therapies like statins and now PCSK9 inhibitors. Our ability to tackle this disease has evolved remarkably.
It really has, and it's so important to emphasize again that effectively managing hyperlipidemia isn't just about popping a pill. It really requires a comprehensive, multifaceted strategy.
Right, not just meds.
It's not just meds. It absolutely has to include those crucial lifestyle modifications we discussed, focusing on a heart-healthy diet, getting regular physical activity working hand in hand with the appropriate use of medications when they're indicated based on risk. It's a partnership.
A partnership between lifestyle and medicine. So,
Gotcha.
as you, our listener, reflect on this intricate balance of lipids within your own body and the really profound impact they have on your long-term cardiovascular health,
Mm.
maybe consider what small yet significant step could you explore in your own life to better support your well-being?
hmm And perhaps what further questions about your own lipid profile, your family history, or your overall risk factors might you want to discuss with your doctor or healthcare professional at your next visit?
Definitely something to think about. That concludes our deep dive for today. Thanks so much for tuning in.